Hi, this is Dr. Poole, and I'm going to give you a pathology overview of the non-neoplastic esophagus. I want to thank my collaborators in this presentation, Dr. Giacatti, Dr. Mahan, and Dr. Lowe, and all of us combined to create the content for this presentation. One housekeeping note again for this course, we'll rely a little bit more on the readings than we did in the preceding course. The readings are a little bit shorter and I think flesh out the presentations a little bit better without listening to me drone on about this stuff. Second thing is, I'll start off with a brief overview of the GI tract, and also for each new organ we encounter, I'll just briefly review the normal so that you have something for comparison as we move along through looking at images. So again, reason why we went over the general pathology is because the disease processes in most organs are similar. So itis is itis. We'll just be attaching different names to it, like esophagitis or colitis. The GI tract is a unique long tubular channel. It actually communicates with the external environment, and it has a typical direction of movement from mouth to anus. The GI tract is a serial placement of organs, which are typically demarcated by functional or sometimes physiological valves or sphincters that control the flow of the food bolus and then fecal stream through the gastrointestinal tract, and also pancreatic and liver secretions as those flow into the gastrointestinal tract. So obviously, since we're talking about directional movement, structure-related problems such as reflux, that is going the wrong direction, obstruction, blockage of the movement, stasis, no movement at all, diverticuli, the movement is misdirected into some other pouch or direction, and perforation are the main problems with the GI tract in general. Each part of the GI tract has a separate function that contributes to the overall directional movement of material. The small intestine is primarily involved in the main function of the GI tract, which is to absorb nutrients. The colon, on the other hand, is function to absorb water and prepare the fecal material for eventual elimination. So the first organ I'm going to talk about in relation to this case is the esophagus. The esophagus is a straight muscular tube that extends from the UES, upper esophageal sphincter, which is a functional sphincter located at the pharynx at around C6 of the vertebral column, and extends into the thoracic cavity to the lower esophageal sphincter, LES. Again, it's a functional sphincter, which is located radiographically at around T11, thoracic 11 vertebral bone. The esophagus functions to as just a conduction tube of food that's been masticated or chewed up and initially broken down with saliva and enzymes found in saliva to the stomach. So it's basically a passageway. It's not involved in absorption. Its main function is just to deliver food from the oropharyngeal cavity to the stomach. It has another important function at the lower esophageal sphincter, and that's to prevent the reflux of gastric acid, which you can imagine, you may have even experienced yourself, can be irritating and corrosive to the lower esophagus. In the adult, the esophagus is about 25 centimeters long, and this can be measured from the incisor teeth to the lower esophageal sphincter, this is used primarily in endoscopy to precisely locate where the tip of the endoscope is. The entire GI tract, from the esophagus to the anus, has the same basic histological microarchitecture. The surface that is exposed to the lumen and external environment is called the mucosa. And this is composed of epithelium and lamina propria. Now the epithelium changes from organ to organ, and so we'll want to pay attention to that. But the same basic mucosal structure is the same throughout the GIT. This mucosal layer rests upon a layer called the submucosa, which has a loose arrangement of fibrovascular tissue and acts as sort of a cushion because the GI tract has to be distensible. So it not only includes directional movement, which we call peristaltic movement, to propel the food in one direction, but it also has to be distensible to accommodate varying volumes of food bolus and fecal material. So the submucosa is sort of a cushioning layer and allows the mucosa to slide over the next layer, which is the muscularis propria. This is a layer of smooth muscle that is wrapped in opposing directions, and this is what facilitates the directional movement of the food and fecal material. And then finally, the serosa is again a loose covering of fibroconnective tissue, and this provides cushion and allows the tubular structure to have some mobility in relationship to other organs. Alright, so let's look at the normal esophagus, the microscopic features. The esophagus is covered by squamous epithelium or squamous mucosa, except for the lowest 1 to 2 centimeters where it meets with the proximal part of the stomach. The muscularis propria is generally composed of smooth muscle, except for the upper or proximal esophagus, in which it also includes skeletal muscle. You might note that it's skeletal muscle that is around the mucosal layer of the oropharyngeal cavity. An important demarcation at the lower esophagus is called the Z-line, and this can be recognized endoscopically and grossly as a transition from the white, smooth epithelium of the esophagus to the tan or pink glandular epithelium of the stomach. And this is an important landmark. Okay, all of this now leads to the pathology overview. So I beg your pardon for that long preamble, but I hope that now the pathology part of it will kind of make more sense. So we'll start off with one of the more important pathological changes that occurs in the esophagus, and that's obstruction. Since the esophagus mainly functions as a conducting tube, obstruction is one of the most important pathological changes that you can find. Obstruction can either be structural, that is, there's some kind of anatomic lesion, or functional, in which there's some dysmotility of the tube, which does not allow it to have smooth directional movement. One cause of obstruction is called stenosis. This is usually due to fibrous thickening of the submucosa, accompanied by atrophy of the muscularis propria. It can either be benign or malignant, and while it can be congenital in cause, most of the causes of obstruction are due to inflammation or scarring. Most times this is due to chronic gastroesophageal reflux, or GERD, which I'll talk about a little bit later. But it can also be due to irradiation or some kind of caustic or chemical injury. Another cause of obstruction are esophageal mucosal webs. These are semi-circumferential ledge-like protrusions of tissue composed of fibroconnective tissue covered by epithelium. And they're usually a delicate web-like growth of tissue. Again, most times this is due to gastroesophageal reflux disease, or GERD, but can also be caused by radiation or, again, some kind of chemical injury. Now, there's a specific syndrome. This is a little trivia, but something that, again, seems to be tested upon a lot, not by me, but in the Step 1 type exam. This syndrome goes by not one, but two different eponyms, Patterson-Brown-Kelly or Plummer-Vinson syndrome. This syndrome comprises the occurrence of upper esophageal webs, iron deficiency anemia, glossitis, and cheilitis. Now, what are those last two terms? Glossitis, as you can tell by the suffix, is inflammation, and the gloss part of it is of the tongue. So this is glossitis, is inflammation of the tongue, which typically results in a smooth, reddened, or erythematous surface of the tongue. What is cheilitis? Well, broadly speaking, cheilitis, which also may be equivalent to stomatitis, refers to inflammation of the lips. But usually when people use the term cheilitis, what they're talking about is angular cheilitis, which is inflammation of one or both corners of the mouth. So this concurrence of these four seemingly unrelated things are what comprise these eponymic syndrome. Now, the final cause of obstruction that I'll discuss, at least of the benign causes of obstruction, are rings. These also are referred to typically by their eponym Schatzky rings. These are circumferential, as opposed to webs, tissue growths of mucosa, submucosa, and occasionally muscle. So these are more extensive and thicker compared to webs, but have the same causes. Most commonly, this is due to chronic GERD or GERD, but can be due to irradiation or chemical injury. Another cause of obstruction, although this one is more functional, is called achalasia. This is due to increased tone of the lower esophageal sphincter as a result of impaired smooth muscle relaxation, so the muscle doesn't relax enough to allow the food bolus to enter the stomach. Achalasia is characterized by a triad of incomplete LES relaxation, increased tone, and a loss of normal peristalsis of the esophagus. Primary achalasia is the result of distal esophageal inhibitory neuronal degeneration, and this leads to the increased tone. This is the most common form of achalasia and is diagnosed by ruling out secondary forms. So the primary is idiopathic. The secondary forms of achalasia may arise in Chagas disease, which is due to a parasite, Trypanosoma cruzi, but more commonly is found in diabetes mellitus, amyloidosis, and can be seen with sarcoidosis. The treatment is usually myotomy, some kind of surgical incision that causes relaxation of the muscle. It can also be physically dilated. Botulinum toxin, or Botox, has also been used. And in severe cases, like the one pictured here, esophagectomy is the last resort. These patients typically present with dysphagia, They can have aspiration pneumonia, obviously because there's a lack of peristalsis and the food kind of sits there. It can result in esophagitis, and there is a small risk of development of malignancy or squamous cell carcinoma. The next pathology that I'll talk about are esophageal lacerations. Laceration refers to a tear or breach in the mucosal surface, and when these are located near the gastroesophageal junction, they're termed Mallory-Weiss tears. Most often this is associated with severe retching or vomiting secondary to acute alcohol intoxication. These are roughly linear tears that are longitudinally oriented with respect to the esophagus and may range in length from a couple millimeters to several centimeters. So they're associated with GI bleeding and hematemesis, or vomiting of blood. Rarely they can be associated with perforation. Most of the time these are relatively superficial. I'm going to talk next about esophageal varices. Varices refer to dilations and thickening of veins. Now, you might know that venous blood from the GI tract typically goes to the liver via the portal venous system and then returns to the heart from the inferior vena cava, or the caval system. At some sites, such as in the distal esophagus, there is actually collaterals between the portal and caval system. So when there's the development of portal hypertension, such as in liver cirrhosis that we'll learn about in a later case in this course, there's congestion of these collateral channels, which result in the veins being dilated and thickened, and these are located in the submucosa. Now, when they become large enough, they can actually cause erosion of the overlying mucosa with hematemesis and massive gastrointestinal bleeding and death. Panel A shows a historical image. Nobody uses really angiograms anymore to document esophageal varices, but I think the image nicely demonstrates the thickened tortuous blood vessels that are running in and around the esophagus. Panel B actually shows in the blue circles collapsed blood vessels. You can recognize them by the reddish streaks that are located just below the mucosal surface. And panel C shows a microscopic appearance of one of these dilated and congested blood vessels beneath the squamous mucosal surface. So you can note that there is not much tissue separating the varicele, or the varix, which is the singular for varices, and the overlying mucosa. So you can see how this might easily tear and result in massive hemorrhage. Next, I'll talk about chemical and infectious esophagitis. So again, we're going back to the term itis. So itis is any inflammation of the esophagus. This can be caused by ingestion of a variety of irritants, including pills, or it can be infectious. This is typically due to 3 different organisms: Candida, which in the oral cavity is called thrush, but we call it just candidial esophagitis in the esophagus, or viral infections, specifically herpes simplex virus and cytomegalovirus. The most important cause of esophagitis is given its own name, which is due to reflux of gastric acid in the term gastroesophageal reflux disease, which I'll talk about after this. These are some images of candidial esophagitis. The panel of the gross gastroesophageal junction in panel A shows a dark discoloration of the mucosal surface. The microscopic appearance in panel B and C show mats of yeast forming on the surface and invading into the underlying mucosa. And panel C shows a high power view of what the yeast and pseudohyphae of Candida appear as. The next slide shows the endoscopic appearance of esophageal candidiasis. Typically, these are white superficial plaques that are usually easily scraped off the surface. Viral esophagitis is typically associated with mucosal ulceration. So you can see the red patches and streaks in the lower esophagus in the gross photo. Panel B shows the typical viral cytopathic effects of herpes virus, including multinucleated giant cells and enlarged nuclei, which have a eosinophilic appearance and sort of a glassy loss of nuclear chromatin detail. Panel C shows a typical feature of cytomegalovirus. Like the name suggests, the cells that are infected are enlarged and show characteristic Cowdery type A inclusions in the nucleus. So this brings me to the most important cause of esophagitis, which is gastroesophageal reflux disease. The causes are multifactorial and there's no single unifying cause, but a variety of different things that contribute to the development of disease. Although we most commonly think of this as an adult disease, it's increasingly recognized as a disease of infant and children as well. Most commonly, the symptoms are heartburn or pyrosis and dysphagia or trouble swallowing. Sometimes the symptoms can be so severe that they can be mistaken for heart disease. Probably more important than GERD itself are some of the complications that it can lead to, including acute or chronic bleeding, ulceration, the development of webs, rings or strictures, and finally, which I'll talk about in a little bit, the development of Barrett's esophagus. Microscopically, the findings aren't terribly impressive, actually. There's hyperplasia of the epithelium in response to the chronic irritation of refluxed gastric acid. There's a mixed inflammatory cell infiltrate in the epithelium. Typically, it's fairly sparse, actually, and usually composed of lymphocytes, occasional neutrophils, and may have very few eosinophils. And this kind of leads to the next category of esophagitis, eosinophilic esophagitis. Now, as the name suggests, the majority of individuals with eosinophilic esophagitis are atopic. So this is another form of type 1 hypersensitivity or allergy. Histologically, the disease is identified by numerous eosinophils, sometimes forming microabscesses within the squamous epithelium. So the panel to the left shows rare eosinophils that may be seen with GERD, while the panel on the right shows numerous eosinophils. A key thing will be identifying a history of atopy or an association with particular food allergens such as cow's milk or soy products. The final entity I want to talk about is Barrett esophagus. This is a complication of chronic GERD seen in about 10% of patients. And what this involves is replacement of variable lengths or patches of the distal esophagus by glandular mucosa and intestinal metaplasia, which is marked by goblet cells. Barrett esophagus is considered a pre-malignant condition because it's associated with the risk of esophageal adenocarcinoma. So it's important to identify Barrett esophagus in patients with GERD to surveil them for the development of dysplasia, which is identifying pre-malignant changes, and these patients undergo routine surveillance endoscopy to identify changes that put them at increased risk for the development of cancer. This is a nice image because it shows in panel A the normal gastroesophageal junction. It shows a very well demarcated transition from the white-pink smooth squamous epithelium to the folded pink-tan glandular epithelium of the upper stomach. Now in panel B, you note in the blue cloud this line, the Z line, is quite irregular, and there's not a smooth transition. Also note that above that, the epithelium has a reddened, roughened appearance, so it's loss of the normal appearance in comparison to panel A. There are a few patches of white epithelium that you'll see in the green circles, but by and large this entire segment has been replaced by glandular type epithelium, which you see in panel C. So there's replacement of the normal squamous epithelium, which you can see in the lower left hand corner, by glandular foveolar type epithelium. That's the normal epithelium of the stomach, and then these large cells distended by bluish mucus, which are the mucus goblet cells identifying intestinal metaplasia and which are diagnostic for Barrett esophagus. Now the importance of Barrett esophagus is that it's associated with increasing degrees of dysplasia. So the panel on the left shows low-grade dysplasia. Notice that in comparison with the underlying and adjacent epithelium, there's loss of the glandular epithelial mucus, and it looks like there's a proliferation of nuclei. In panel B, these changes also include nuclear enlargement, hyperchromasia, and loss of polarity. That is, loss of the nuclei typically located near the basement membrane, and there's increasing glandular complexity. Not all patients with Barrett esophagus progress to this. A small percentage of patients progress to low-grade dysplasia, and out of that group, a small percentage progresses to high-grade dysplasia, and then out of those, some patients will progress to outright cancer. So let me wrap up for you. There's several important causes of obstruction, including stenosis, webs, and rings. I talked about achalasia, which is more of a functional type of obstruction in which there's narrowing of the esophagus. Usually these are functional and dynamic. Rarely they can be anatomic and fixed. There's primary and secondary causes. I talked about laceration or Mallory-Weiss tears, varices, which are the consequence of some kind of portal hypertension, and which are important for a cause of massive gastroesophageal bleeding. Then I talked about esophagitis. There's a variety of different causes. When caused by gastric acid, this is called gastroesophageal reflux disease, or GERD. When it's caused by a type 1 hypersensitivity and associated with numerous eosinophils, it's called eosinophilic esophagitis. One important consequence of chronic GERD is Barrett esophagus. Initially, this just involves metaplasia, or changing of the squamous epithelial surface to a glandular epithelium with intestinal mucus goblet cells, but this can lead to progressive dysplasia and even neoplasia or malignancy. So thanks for your attention. I'm sorry this talk ran on a little bit. Thank you.